Good afternoon, and welcome to the virtual town hall for February 5th. Thank you for joining us today. This afternoon, in addition to a brief update on the COVID-19 vaccine program, we're going to devote a significant portion of our meeting to the Anti-Racism Oversight Committee. This group was initially convened several months ago, and today the two co-chairs of the Anti-Racism Oversight Committee will discuss the work that's been done and the committee's ongoing work. For both of these presentations, we'll be monitoring the chat box for questions for Q&A at the end of the session. We have noticed that oftentimes questions are submitted that later are answered during the presentation. So you may want to wait and hear most of the content before sending in a question. In the next few town halls and in the future, we'll be routinely allocating time on the agenda to discuss our efforts to eliminate discrimination and racism. I want to stress that the importance of our culture and of our climate cannot be overstated. To succeed to our fullest, we must focus on culture and climate, and I and our entire leadership team is behind this 100%. This is a core principle of our anti-racism efforts. We are at our best, and we provide the best care, the best training, the greatest innovation, and the most caring care when we practice and promote equity, respect, and inclusion. These are key components that we will focus on to improve our culture and our climate such that our community will be stronger and more productive. Of these key components, the first is we are committed to support those who speak up to escalate incidents of bias, discrimination, or harassment. Second, we're committed to stop retaliation and eliminate the fear of retribution. Third, we're committed to raising our own awareness through education, dialogue with others, and cultural sensitivity. We have all been through a crisis in the past year, and we still have a long way to go. Treating each other and those in our community with respect and equity will help us to continue to be resilient and to continue to advance health for Michigan and for the world. Now I'd like to introduce Dana Habers, who will be speaking about our COVID-19 vaccine program.
Thanks, Marshall. Good afternoon, everybody. Thanks for having us back. Let's go ahead to the first slide. So we continue to do our part in the vaccination rollout across the state. And I think today's focus is somewhat more global. We're going to talk a little bit about activity happening at the federal and state levels and how that impacts our operation. But we do continue to operate, particularly this week, in a little bit different format to achieve our guiding principles. So just as a quick review, we are committed to doing everything we can to vaccinate all members of our community as quickly and safely as possible. We are working really hard to make sure that we're protecting the populations at highest risk of severe COVID disease. And we are responding to this public health crisis in coordination. And this is not only with the state and local government agencies, but also with peer institutions. We're working closely with IHA and St. Joe's and the VA and others to make sure that we're capturing our entire community. Next slide, please. Quick stats. So far, we have vaccinated 20,106 of our phase 1A and 1B recipients fully with both doses. We began administering Moderna this week, so we have two different series. Moderna vaccines are being administered out at our Brighton Health Center facility, and we continue to administer Pfizer second doses at our Stadium site. Our Ford and Danto are on their last few days here. We shut down Ford Auditorium. That was our first dose administration site, and Danto will wrap up this week. So we'll really be consolidating our vaccination sites. And some of that is in response to what I'll talk about in a moment about vaccine supply. Total doses administered, we had our 50th day of vaccination this past Tuesday, and broke the 50,000 mark on the number of doses administered. So pretty incredible progress, and just want to make sure that we always commend the team working really hard to get this done behind the scenes, day and night and weekend, holiday. They're really plugging away still. So thank you so much for everything you've done, and this is really great progress. Next slide, please. So this week we experimented. We decided to take the vaccine on the road. And I know that that comes with some pretty significant pharmaceutical logistics. We are really deeply committed to not wasting any doses. So there's a careful calibration of the number of appointments that were scheduled this week at our Flint and Dearborn sites. And we also did some work to try to reach out to some of our patient population that qualified but is homebound and has been unable to get to some of our mass vaccination sites for their vaccine. So this has, I think, an incredible kind of layered approach. We've talked about all along having this commitment to both mass vaccination and the efficiency that we can gain from that infrastructure, but also making sure that we are reaching the populations that don't necessarily have the means to come to us. So it's been a really fruitful week, and we're excited to have administered more doses out in the community. Next slide, please. So what's going on? Let's start, I think, at the federal level. Next slide, please. As you all know, we have a new federal administration. There's a new plan that was produced in January called the National Strategy for COVID-19 Response and Pandemic Preparedness. And in it, there's a variety of different information. You can go and do some homework and read up on it, but I've bulleted out the things that I thought were relevant for our vaccination effort here. So I'll take the time to read through them because I think this helps set the stage for what's happening kind of as we continue our program locally. So there's been an incredible effort to try to get more vaccine. Many of you know, in the last 3 weeks, we've had very limited, if at all, first dose appointments. We've continued our commitment to administering second doses to all of those who have received their first from us. This plan includes the acceleration of shots into arms and an overall increase in the volume of vaccines that are coming to not only the state of Michigan, but more broadly across the country. There is a more targeted focus on hard to reach and high risk populations, and I'll share how we're doing that. There is a commitment to fairly compensate providers, the states and local governments for the cost of administering vaccines. There is an effort to drive equity throughout the campaign and broader, even not with the vaccine itself, but with the broader COVID-19 response. There's effort to launch a national vaccination and public education campaign. And we have many faculty, not only within Michigan Medicine, but beyond across our university who are contributing to this in many ways and working on research and education to reach those who are maybe vaccine hesitant or fearful of what the vaccine might do to them. So a lot of work underway for this portion of the population that's just not sure yet. We are under this new plan, there's a lot of work to monitor vaccine safety and efficacy. And then there's the really important one is the last bullet, a surge of healthcare workforce to support the vaccination effort. So far in the state of Michigan, there have not been additional resources. We've been doing some work with National Guard to stand up in kind of micro operational ways, but this is a much broader investment in the infrastructure to be able to expand the capacity to vaccinate. Next slide, please. And what you'll see is new sites popping up that are not necessarily large health systems or even local health departments. So there's a list here of, and not all relevant to us here in Michigan, a few of them are. Walgreens, Meijer is on this list. These are federal pharmacy partners who will begin to vaccinate within kind of corner store pharmacies and other locations. So you're seeing a distribution from kind of centralized mass vaccination sites that were concentrated in health systems originally. And I think that was aligned with the phase 1A priorities and the efforts across the country to make sure that the healthcare infrastructure could continue to function to take care of COVID and non-COVID patients throughout the pandemic. Now it's getting really out into the community much further. Next slide, please. And in Michigan, so there's we participate in a partnership with GE, and there's some data that they've been able to share with us, and just wanted to give you highlights. So as a nation, and we are behind other countries at this point, 1.6% of the total US population has been fully vaccinated. So that's first and second doses. Within Michigan, we've administered first doses to 8% of our total Michigander population, or just over 1 million. And then 2% of our total population has had both doses. So we really still have a long ways to go. Next slide, please. I'm going to shift gears and talk about Michigan's plan. So these are slides from the MDHHS deck that was also distributed at the end of January. And these are really important goals. There's zero disparity, that there is no disparity in vaccination rates across racial and ethnic groups or by what's called the Social Vulnerability Index. And I'll talk about that in a moment. There's a goal to have 20-minute commute time, however your mode of transportation, to a vaccination site across the entire state. There's a goal to get 70% of Michiganders age 16 and up vaccinated as quickly as possible, and to have 90% of the doses received administered within 7 days of arrival. And these are not new statistics for us here at Michigan Medicine. We've been able to do that. 95% of people getting their second dose and vaccinated within the state's expected timeframe, which is really a summer timeline. Next slide, please. So to share a little bit more about the CDC's SVI, or Social Vulnerability Index, and this is really fascinating. If you haven't heard of it before, I encourage you to spend some time Googling and learning more. There are actually 15 different data points that are involved and collated into a single metric. And this allows, even in a broader emergency response situation, the government to know where they might need to add additional layers of resources to reach communities. So it includes variables like socioeconomic status, those who are either unemployed or who have a low income, people who, there's some demographic information from the census around age and disabilities and whether or not a household potentially has a single parent. There's minority status and ability to speak English as a primary language. There's housing types and transportation dependencies. So people in multi-unit structures, for example, or mobile homes, for example. And then what the state is doing is now combining this concept of the Social Vulnerability Index with their distribution of the doses that are coming into the state of Michigan. So the intent is to get more doses to those counties where the SVI is higher, in the anticipation that that's also a community that's really faced a higher and harsher impact of COVID-19 disease. So there's a kind of reconciliation between the impact of COVID-19 on communities and now our effort to vaccinate more expediently in those populations. Next slide, please. It's a lot to absorb on a slide, but this is straight from the MDHHS website. I think we get a lot of questions about our prioritization and where we're at. We've consistently applied the state's prioritization schema to our vaccination program. And so you'll see right now we're in the month of February administering to phases 1A and portions of 1B. And there was a shift in inclusion of age 65 and older in 1B right before we went live and rolled into that. That was driven off of, again, that work around equity and making sure that distribution is equitable to different populations across the state. And when you layer in the average life expectancy of, for example, the all race calculation across the state of Michigan, average life expectancy is 78 years old. For the Black community, that is 73 years old. So if we were distributing exclusively to people age 75 and up, that would have disproportionately given more doses of vaccine to a primarily non-Black population. So there's a lot of work happening within the detail of these decisions to try to make sure, again, that we are meeting the needs of the community and really focusing distribution of the vaccine as quickly as possible to those communities most negatively affected by COVID-19 disease. Next slide, please. And I think, unfortunately, as I mentioned, we are still in a lull on vaccine supply. And this is an experience that we're seeing not only within the health systems, but also in Washtenaw County and Livingston County and some of our local health departments. So we are in 1B actively. We continue to capture some new 1As. You know, if we have new employees who are hired into the 1A group, we get them in the queue and get them vaccinated if they're interested. We also are chipping away at our 1B, but it's been really painfully slow because of the inability to administer first doses. We recognize that this creates a lot of anxiety, particularly with our patients who are age 65 and up, and we're working with the health departments and others to figure out how we better distribute in line with this new, very geography-based model. So we understand that the doses are intended for certain populations now, driven by the state, and our role is shifting from, all right, how much vaccine can we get, to more of a, what can we do to help? And really stepping up and serving in ways that are maybe even outside of clinical delivery of vaccine, that we may be able to support efforts because of infrastructure that we built or because of an established patient provider relationship and so on. So we're really in this together and working towards, as many of you know, as quickly as possible, getting this vaccine out to everybody. I do have an optimistic lens on our future vaccine supply. We're hearing a lot of really encouraging that Biden plan, and the administration and the state level is telling us that there would be increases in the mid-teen percentage, 16 or so percent increase in the coming weeks. While we may not see that within our own institution, I think statewide that is happening. And we are really encouraged to start to see some areas of the state that maybe weren't getting any vaccine even are starting to get vaccine into their population. So we really are staying the course and continuing to partner and working through this together to fight COVID as a public health crisis kind of intervention. So I appreciate everyone's support, and happy to answer questions at the end. Thank you. I'm going to introduce now my colleagues, Phyllis Blackman and Dr. David Miller, to talk about our next subject, the Anti-Racism Oversight Committee. Thank you.
Thank you, Dana, and good afternoon, everyone. I am Phyllis Blackman, and I, along with my colleague, Dr. David Miller, are the co-chairs for the Anti-Racism Oversight Committee. We begin each of our Oversight Committee meetings with the following Michigan Medicine anti-racism statement. Michigan Medicine unequivocally recognizes racism as a public health issue, and we should be standing out as leaders against inequality. We are committed to creating fundamental change that leads to a culture of anti-racism and a medical school and health system that are leaders in equity, justice, and inclusiveness for people of all colors. Next slide, please. It is our pleasure to give you an update of what we have been doing over the past 6-7 months for the Anti-Racism Oversight Committee. As you know, our committee was established in July of 2020, and our charge was to identify practices that contribute to racism and recommend changes in Michigan medicine if needed. And we are to identify an approach that achieves an anti-racist culture and utilize the diversity, equity, and inclusion dashboard to check the progress and outcomes. We were also charged to develop and recommend a plan around contributions we can and must make to eliminate racism and inequities that exist today at Michigan Medicine. Next slide, please. We are pleased to show that we are moving forward and with completion of 2 of the phases of our timeline. And we are approaching completion of phase 3, and that is to finalize and present our action plan and to develop and implement our communication plan, which we are well on the way to do and will be able to share with you. Phase 4 is in progress, and that is the implementation of our action plan. Next slide, please. I want to take some time just to talk about our 6 subcommittees, and I want to thank and congratulate all of our co-chairs and our committee members for their commitment in making sure that we have solid goals and can move forward with the action plan. There's been a lot of time and sacrifice to do this, so I want to make sure that we acknowledge each and every one of our committee members, so thank you. Our co-chairs for our Speak Up and Show Solidarity are Steve Vinson and Vic Sukumar. And I want to take some time just to talk about or share the goals so that when we go into the next few town halls, you'll have some questions and that you will be able to ask as you have been able to hear the goals today. So the goal for the Speak Up and Show Solidarity is to foster an inclusive culture of anti-racism by providing Michigan Medicine with an escalation framework, education, and tools so we feel safe when speaking up and showing solidarity against unlawful bias and discrimination. Our opportunities for conversations are co-chaired by Mary Freer and George Mashur. And the goal of this committee is to create sustainable opportunities for formal and informal conversations throughout Michigan medicine, addressing racism in a psychologically safe environment. Next slide, please. Our Education and Clinical Practice Subcommittee are co-chaired by Michelle Cart and Keith Grand. And the goal of this committee is for learners and educators in UME, GME, CME, and graduate studies across Michigan medicine and the medical school should be competent and have access to curricula and best practices developed and with expertise in intersectional framework and health justice. Our Diversity and Workforce Subcommittee is co-chaired by Paul Sturgis and Justin Dimick. And the goal of this committee is to identify critical factors in Michigan medicine's demographic composition by increasing our underrepresented minorities workforce and recommend targeted short and long-term actions for implementation. Next slide, please. The community work is co-chaired by Keith Dickey, Elfrida Rooks, Ebony Parker Featherstone. And their goal is to ensure that our clinics serving minority and struggling patients receive the same level of resources and support as others, to ensure equal access to care in our health system, and to take a leadership role in addressing health disparities within our state. Our Advocacy and Professional Development Subcommittee is co-chaired by Becca Ashley, and Brian Cole. And the goal of this committee is to integrate anti-racism values into our everyday work as a sustainable element of our medical community and culture, and direct the inclusion of dedicated time and resources to faculty, staff, and learners for leadership, professional development, and advocacy. So as you can see, these are some very, very strong goals that the committees have, and that the work that they are doing is proven to be challenging, but yet attainable. Next slide, please. So as I said, in future town halls on February 19th and March 5th, the AROC subcommittees will be able to give you a more in-depth look into their action plans. They have already completed some of the actions, deliverables, and the deliverables within the next 6 months will be able to be shared in our next town halls. And so some of those objectives already completed, for example, an approved leadership statement related to creating safe spaces for speaking up. This was one of the deliverables that was brought by the Speak Up and Show Solidarity subcommittee. And from our Education and Clinical Practice, one of those deliverables is a comprehensive review and approval to eliminate 6 of the 11 race-based national and/or standardized clinical measurement tools. This was really an enormous amount of work, but as I said earlier, there is a committed group of people that are working to make sure that they can deliver on those items that were identified. And we will hear from our community group, Michigan Medicine's participation in the Health Anchor Networks. And I look forward to the questions that you will have for these subcommittees, and we will be able to carry on those discussions in the community conversations that is hosted by the Office for Health Equity and Inclusion, and that's every Thursday. So I encourage you to think about these, the goals that these committees have, and have some questions and be able to have dialogue with them. So right now, I'd like to turn this over to Dr. Miller, and he will continue on with our presentation. Thank you.
Thank you, Phyllis. Good afternoon. I'm David Miller, and I'd like to start by thanking Phyllis and all of the members of the Anti-Racism Oversight Committee for their exemplary leadership and commitment as we continue moving forward together. Phyllis presented a broad overview of the plans and recommendations brought forward by our 6 subcommittees. Our work now has transitioned to the critically important point of creating partnerships across the organization to implement the recommendations of the subcommittees and to make changes that become part of our culture and of our work every single day. This slide provides an illustration of the breadth of our established and emerging partnerships with departments, programs, and units across the organization. And the exciting thing is that there will be many more partnerships related to the Anti-Racism Oversight Committee that we cannot even list on this slide. We're truly grateful for these partnerships as we move forward toward implementation. Could I have the next slide, please? Another key aspect of our ongoing work is what we are actually starting today, namely broader communication regarding the work of the Anti-Racism Oversight Committee and our commitment to an anti-racist culture. Importantly, this communication plan involves not just presentation of information, but it also includes listening. We're committed to creating platforms for listening and to better understanding perspectives from minority and underserved populations in our communities about Michigan medicine and all that we do. By listening, we can learn in a way that allows us to improve equity in healthcare across all of our missions. Listening is also needed to build trust with our diverse community and to allow us to continuously improve the work of the Anti-Racism Oversight Committee as we move forward. By listening and sharing information regularly, we hope that we can also provide transparency and clarity for our teams and our patients about the progress of our work and the efforts of the Anti-Racism Oversight Committee. Could I have the next slide, please? In terms of specific details, we have already scheduled our first community listening town hall for later this month. On February 23rd, Michigan Medicine leadership, along with members of the Anti-Racism Oversight Committee and key community leaders and stakeholders will join together to listen to the needs of our community as a first step toward increasing community engagement and trust. We will also be communicating internally, including during each of the next 2 town halls, where leaders from our subcommittees will present additional details related to action plans and progress. We will also engage in community conversations that will allow more detailed dialogue, understanding, questions, and feedback. We're grateful to Dr. David Brown, who has agreed to provide information about the Anti-Racism Oversight Committee's progress in monthly DEI updates. We will also share information in headlines and on the website for the Office for Health Equity and Inclusion. We anticipate sharing information across many other different communication channels as well. Could I have the next slide, please? Ultimately, our aspiration is to achieve an anti-racist culture and to eliminate racism and inequities at Michigan Medicine. We're optimistic about achieving this goal, but we also must hold ourselves accountable, and we have to evaluate progress toward these outcomes. How do we do this? There are many different outcomes that we're trying to achieve. These include a workforce that feels respected, an organization where diversity and teamwork are deeply and demonstrably valued. In addition, as Dr. Runge mentioned at the outset of the town hall, we're committed to an organization where there's confidence that reporting discrimination and harassment is safe and free from retaliation. We also must make sure that our team members are aware of opportunities for advancement in our organization, that we have unbiased recruitment and retention strategies, and that our leadership demographics reflect our workforce. To do this, our committee is committed to specific and purposeful review of data related to our workforce, as well as to evaluating specific responses and outcomes from our employee engagement and satisfaction surveys as a way of understanding the degree to which we're achieving change in our organization. Finally, I believe that we can catalyze achievement of these outcomes by demonstrating our values of caring, integrity, inclusion, innovation, and teamwork every day in both the big and the small moments. We look forward to sharing more information about the progress of the Anti-Racism Oversight Committee in the weeks, months, and years ahead. We're grateful for the partnerships that exist and those that will be established in the future. And we're deeply thankful for the commitment to this work across the organization. Thank you again, and I look forward to our continued work and progress. At this point, I'll transition to Keith Dickey for the question and answer session. Thank you.
Thanks, David, and thank you all. So we'll turn now to the Q&A portion. Let me start by reminding folks that if we can't get to questions here during the remainder of the town hall time, you can also go to mmheadlines.org and click on the ops update, and that's where you'll get to the many FAQs that we've been compiling and trying to answer questions on vaccine, on HR matters, and these other issues that come up during our town hall sessions. So with that, actually, David, let me start with one question for you. If you can come back for a second, David Miller, Dr. Miller.
I'm back.
Thanks. David, one quick question for you. Given the stabilized COVID-19 census, will there be a review of visitor restrictions?
Thanks, Keith. That's a great question, and one that I think is appropriate and that we're considering very carefully in the organization. And I think for all of us, we know how difficult it is both for our patients and our families and our teams with the current visitor policy. We're taking a data-driven approach to assessing this and working in partnership with our infection prevention and epidemiology colleagues. We're looking at a number of data elements, including our census, rates of positive testing in the community among patients and among team members, and comparing those values to our status both in the spring and over the summer. And we will use that to help make decisions. We've not reached the levels we were over the summer to make changes in the visitor policy, but we're reevaluating that and looking at those data weekly. And I don't know if Lorraine maybe wants to add any additional information related to that question, Keith.
Yeah, that'd be great. And if I have one other question for Lorraine, if she is available.
The visitor policy has infection prevention as a core value as we look at it, but it's weighed against all the other important reasons why we have visitors and family members for patients. And so we're clearly following any healthcare associated cases among patients as a metric, rates of community transmission rates in our employees, and also in mind the new COVID variants and their likely increased transmissibility, and also in mind that we have some increased numbers of cases locally in our campus. And those may not hit exactly the metrics that Dr. Miller was talking about, but they are an important consideration.
Thanks, Lorraine. And your audio is a little soft, so if you could speak up or lean in. Just one other question for you. Somebody writes, does Michigan and Medicine allow bandanas with the bottom open and neck gaiters in our facilities and vaccination sites? This person's is expressing some concern around that.
Yeah, and I understand the reason for concern. There have been some studies that look at less protectiveness around the bandanas and the neck gaiters, particularly because they don't fit as well to the face. They're not our preferred type of face covering. And I'll be honest with you, I don't want to answer this question exactly yes or no, because we've talked about it a number of times and I'm not certain what the current policy language is.
Okay, well, that's great. We'll make sure to answer that fully in the FAQ. Thank you, Lorraine. Dana, if you could pop back on number of vaccine-related questions to start, and then I'll turn to Sandro as well.
Thank you.
Yep, great to see you again. Thank you. So one question, are we expecting our allocation of vaccine from the state to decrease in the future as the state diverts doses away from hospitals, as has been announced in the media?
Yes, the short answer is yes. To what degree we are unsure. We know that the percentage split of the total vaccine coming into the state will be higher for local health departments and lower for Michigan Medicine and other health systems or hospitals. We don't know the raw total number coming into the state, so what that looks like from a net number, but we do anticipate more and more will be shifting away from entities like Michigan Medicine. Yes.
Thank you. Next question. What happens to extra vaccine that may be left over at the end of the day? Does Michigan Medicine have a mechanism in place to reach out to patients who can be on standby to receive leftover vaccine?
Yes.
I think we've answered this question before, but it's worth probably saying again.
Yeah, it's a fantastic question. So we aim not to waste a single dose. So if we open a vial, I think most of you know that there are multiple doses per vial, 5 to 6 for Pfizer, and I believe 10 for the Moderna vaccine vials. If we have vials that are open, they will not last overnight. So we have to use that dose before the staff pack up and go home for the day and shut down the vaccine clinic. We have a process for doing that. It reaches out to originally our volunteer vaccinators, for example. We're a workforce that were there and in all practical terms available to be there and get ready to get vaccinated. Now that we've worked through the majority of those, we're working on pulling in patients who are scheduled out a few days and are able to come in early. They are on a standby list and can come within 15 minutes or so at the end of the day and be there quickly to be able to get their vaccine a little bit ahead of schedule. So we do have a process for that. And it's not an open standby list for just anybody. We're really preserving the integrity of the priority in that process.
We're talking about very few doses, right? I mean, I know that as the day winds down, we're not opening up new vials left and right.
That's correct. Yeah, the team on site, the nurse managers there are really tuned into this and know very well how many patients we have on the schedule towards the end of the day. And they're not reconstituting unless we need it for the scheduled appointment. So it's a really tightly well-run process, thanks to Tom Mann and the team there on site.
Great. Another question for you. Is there a standby or wait list for non-Michigan Medicine employees to fill in for appointment no-shows? How would an eligible person sign up?
We don't have a wait list for no-shows currently. That no-show rate is actually pretty slow or pretty small. Most people, when they have their appointment, are coming. There was one day, I think it was New Year's Day, that was a holiday and that was snowy, and we had some no-shows that day. But we don't fill those appointment slots. Instead, we would just not open enough files for that appointment, right, and follow that same end of day process. So we're not wasting vaccine.
Okay, and a couple data questions for you. One person asks, do we have data on those that are not getting their second shot?
Yes. Yes, and we are doing, there's a variety of different outreach happening as a result of the data that we have. So we have data that shows, for example, you all remember if you completed the Blue Queue that you may have checked, you wanted to wait and learn more about the vaccine before you sign up for your appointment if you're eligible in a phase we're serving. So we're circling back and providing some education to both leadership teams in those units, as well as Sandro and Stan have done a really incredible job of going out and meeting with teams in their huddles and going to staff meetings and that sort of thing to answer questions and provide more information. So there's outreach there. And then for people who are not coming back for their second dose, it's a very, very small number. And it typically is a matter of time frame. So, there's for Pfizer, the 21-day return time. And if they haven't booked by 21 days, typically they're getting an appointment within the next week or so and coming back. So we haven't had a large portion of patients that are recipients of the vaccine that have not gone through both first and second doses.
And this next question came in, I think, in the midst of your talked, and so I may be referring to a specific slide. So if this doesn't make sense, we can punt it. But one person writes, out of all those immunizations, and I think maybe referring to your total slide, how many have been non-employee patients of Michigan Medicine? And if you don't have the number, we can answer
That
that.
is a fantastic question. That's a good pop quiz question. I don't know the number off the top of my head, so I'll have to get
Okay,
back, but we
that's
do
fine.
have the number. Yeah.
Let's see here. What group do UM Residence Hall food service staff fall under? The UM record stated that food service workers have received vaccine invitations, and this individual has 2 sons who are food service workers, and they've not heard anything.
Yeah, so this gets into the complexity of phase 1B. So for people who are outside of the direct or indirect patient care supporting the infrastructure of the healthcare system, there is a definition in phase 1B, which is we're currently serving, that includes people who are by nature of their work and are also involved in a critical industry identified by the state, unable to social distance. So that does include some of our food service workers. There were also food service workers who were included in 1A if they, for example, provided food to the dorms where there were COVID positive patients quarantining. So it really gets into the detail of what type of food service worker and where you're working and what kind of the nature of your work is. It's difficult to answer that question broadly. It sort of depends.
Okay. And my assumption is for this individual, if those sons have filled out the blue queue, and then they should be in the system. And if they haven't filled out the blue queue, they should go ahead and do that.
Absolutely. Yep. And then we'll get to them. Yep.
Great. And then Dana, one more question for you. Because of the location of parking, et cetera, the stadium doesn't seem to be a good option for our elderly population and others who may have mobility issues. Are there any plans to open another site for those in Ann Arbor area who have mobility issues? And is there a plan to set up a drive-through option now that a number of cases of the new highly contagious variant is increasing in the UM Ann Arbor area?
The first question is about access and accessibility of the stadium site. And I think we've done everything we can to make it a very accessible, very patient-friendly site within the boundaries of what that facility can do. We had plans to launch a second site over at North Campus, which would have had additional parking and easy access from public transportation hubs, as well as kind of right off the freeway with, but again, that did not launch and will not launch unless we have the vaccine to support that. And actually at this stage, we think that it is unlikely. We think it will be more likely that your second question, the drive-through options or these more community facing, especially with vaccines that require a single dose injection, come online for us. We think that the direction will be to shift more towards those kind of community facing, broader public health atmospheres for vaccination delivery.
Great. Thank you, Dana. Let me ask Sandro if he'll come in and answer a couple vaccine technical questions.
Hey, yeah, I'm here.
Very good. Dr. Sinti.
Yeah, hi.
One question, once the J&J vaccine is released under EUA, will immune compromised patients preferentially be given the mRNA vaccines from Pfizer and Moderna so they don't have live virus exposure? Do you want to answer that question?
Wow, it's hard to answer at the moment, and what you're getting at is it's an adenovirus vector. The virus doesn't replicate, so it shouldn't be a problem. The ACIP will probably weigh in on that, but I suspect that immune compromised patients will still be able to get that vaccine.
And then one question people were asking, how do you advise the use of over-the-counter painkillers, NSAIDs like ibuprofen or Tylenol in relationship to the administration of the vaccine?
I use them. I used them when I had pain and muscle aches after my second shot. I don't think you need to do it beforehand. I think doing it afterwards is fine. But there's definitely using Tylenol, ibuprofen is probably a good idea if you get the muscle aches and particularly fevers too. So,
thanks. Here's a really question of advice. Very few of our patients 65 and over with pre-existing conditions have been invited to be vaccinated yet. We all know and understand that why that is. What do you tell a 74-year-old diabetic with cardiac stents, for example, about vaccine prospects?
Yeah, well,
is there
they're good.
guidance on what our providers should be saying to patients like this?
The vaccine prospects are excellent because they're in the current phase right now, but we're waiting for more vaccines. So I think all you can say is you need to wait. It's not based. The other thing to say is we're not sub prioritizing for either, as Dana pointed out, the 75 or above, we're not doing that, nor are we sub prioritizing risk factors at this point. So that person is in the same pool as others. And I think that's important for them to know up front. If we're going to be honest about this. Yeah.
Thank you. And I think, Sandra, you can also speak a little bit to this. How is Michigan Medicine collaborating with Washtenaw Community Health Department right now?
Oh, yeah. And Dana may want to weigh in on this too, or Stan. We're very actively involved, and we have a weekly meeting now that includes Washtenaw County. We were meeting weekly and even more than weekly with Dr. Marquez from the health department, but now we have a meeting that includes all the hospitals, that includes the VA, St. Joe's, IHA, and the health department. And we're going to need to work very closely with them and send out messages that are clear and understandable to the public about what we're doing, because vaccine is, as Dana was saying, is going to come mostly to the health departments now, and we are there to help, and we want to be able to help. So we're meeting a lot with them today, as a matter of fact.
If I could add a little bit to Sandro's insight on the first question, I think it's a really important thing to recognize that a lot of our physicians, our faculty, have very strong relationships with their patients. And we're hearing that when we do, for example, outbound phone calls. You know, we have a group that's calling for non-portal patients to reach out and let them know it's their turn if they'd like to get vaccinated. And we hear that they want to talk to their doctor first and learn more about it first. So I think that relationship is really critical. And I appreciate our faculty having those conversations now and encouraging them. I think there's from a practical tip, maybe the shift in vaccines to the health departments means patients of Michigan Medicine may be able to, in all practical terms, get an appointment for their vaccine through a health department before they were to get an invitation from us. So I think what we're trying to encourage in all of our communications is just to sign up. If you just go to your local health department website. Most of them have information on how you sign up for a vaccine through them if you're in a qualifying phase, and they're following the same prioritization as we are. We're all consistent across the state on that. Then just go wherever you can soonest. You know, this is good advice, I think.
Thank you both. With that, I think we'll transition to AROC related questions. So I'll let you both go. And if Phyllis and Dr. Miller could join us back again, we have a handful of AROC related questions. Thank you both. Let me start with this one. My person asks, why is the makeup of the AROC executive committee so executive and MD heavy? Shouldn't there be some representation from environmental services, from PSAs, et cetera? Does one of you want to tackle that?
So yes, I will tackle that. So as we originally set this committee up, we had to have leadership sponsors in order to move this work. And we have the appropriate people at the top to help us move forward. Now, our subcommittees, as well as our co-chairs of our subcommittees, are not all physicians. They are faculty, staff, learners. They encompass the entire committee. And it was intentional to make sure that these committees were inclusive at all levels.
Thank you, Phyllis.
And Keith, I could add, it's a very important question and a very fair question. And I think, the establishment of the committee occurred in the context of the existing diversity, equity, and inclusion structure. And we wanted to partner with that. Part of the goal of the committee as a whole has been to connect and accelerate work that has already been happening. And so we thought it was important that we part of that, but then to have very broadly representative teams in the committee as a whole. And as Phyllis mentioned, we've been very purposeful that the teams include faculty, staff, learners from across the organization. And we have been purposeful about connections to Michigan Medicine resource groups who are offering additional insight and perspectives about the work. So I think it's a very important and fair question, and one that we are trying to be very purposeful about making sure that input is being received from across the organization.
Thank you. And one other person had written, what was the application process for being on the AROC committee or subcommittees? And I think what you're telling us is, in fact, you constructed all of these committees and subcommittees very, very thoughtfully in order to make sure they had the right mix of diversity, perspective, and expertise. So it was not an application process. It really was a selection process with a lot of thought and intent. Is that right?
And I'll briefly answer then, Phyllis. The reality is we're so grateful for the outreach we've had from all over the organization. And whenever we receive interest, we try to connect colleagues from across the organization with leadership of the subcommittee, recognizing that our work will be ongoing and we will need everyone in the organization to be contributing. And so we're grateful for that. We're looking for continued partnerships. As I said, the slide we showed, which showed the many partnerships we have, the exciting thing is that we couldn't even represent all of them on that one slide. And so we are grateful, and we want to continue to have colleagues from across the organization joining us in this work.
Hear, hear. Another question for the two of you. Is UM or Michigan Medicine providing resources, i.e. budget, towards the goals of AROC?
So I will start, and and David will be able to add to this. What we strive to do is to utilize our partnership and existing resources to get the work done. There are so many of our colleagues are the content experts and may be doing the work already. And so we reach out to our colleagues and see, can this work be taken on within the scope of the work that they're doing? But at this time, we don't have a designated budget per se for this work.
Thanks.
Thank you, Phyllis. And I will add, but so Phyllis and I have been in meetings and conversations with, leadership from across the organization, and we have received, I think we're thinking about it in a couple ways. As Phyllis mentioned, that the work that we are proposing is part of our culture and everyday work. And so there are many opportunities to take advantage and partner with kind of existing resources across the organization. But we also do have commitments for incremental resources, recognizing that the scope of the recommendations from the subcommittees, as we will see in future town halls, some of them are shorter term, some of them are longer term with associated investments and resources, and we do have that commitment.
And related to that, what are AROC's plans for getting buy-in from minority staff along the way?
Well, there are several opportunities. We have resource groups. We have the Black Resource Group, and those and several other resource groups that people can join in, ask questions, and let their voices be heard from there. And once I receive a report from those resource groups that I can actually incorporate into the AROC work. So we want to make sure that there is a place for all voices to be heard. And this will be encouragement for our minority groups to be able to make sure that their voices are heard and be engaged in the work.
Yeah. Thank you. I think another, very, very important question. I think, as Phyllis mentioned, part of this is making sure that, and I said this in the update, that we are listening. And that listening occurs in a number of different settings that we're adjusting in response to that feedback, and that we're following through on our work and recommendations. And so we're transitioning into that phase of our work, and we talked about what we will be measuring and how we will be trying to hold ourselves accountable to the progress, and all of those factors together, I think, will hopefully continue to build trust in the organization that we're committed to this, that the work, the aspiration to achieve an anti-racist culture, to eliminate discrimination and inequities, to make this part of our everyday work. And in doing that, we will gain trust. We will gain continued trust, buy-in, support, and partnership over time.
Thank you. Okay, just 2 more questions for the 2 of you. The first one's really a data question, and Phyllis, you may know the answer to this. Is the makeup of our Michigan Medicine workforce by role and by area available? And then it says to the community workforce, but I think what that person means is that kind of data about the makeup of our workforce publicly available in some manner? And if so, where would that be located?
So we have our DEI dashboard, and your DEI leads have access to that dashboard, and it does collect the data that has been mentioned. And so working with your DEI leads, your DEI vice chairs, and the chairs of your departments, and those that have gone through the training to use that dashboard would have access to it. So check with the DEI leads.
Perfect. And here's another really a DEI question, but I'll put it to you, David, since we've got you on the spot anyway. What is Michigan Medicine's plans to diversify executive leadership? Are there any plans to retain the amazing talent you already have that is underutilized?
I think it's a very important question, and it's reflected in many ways in our organization and in much of the work being done by the Diversify the Workforce Subcommittee. And I think that there are, several key components to that. I think first is having the right approach to recruitment to begin with, identifying diverse candidate pools and ensuring that we have diverse committees involved in searches for executive leadership positions and being consistent and principle-based in that. I also think that retention strategies, once colleagues are in positions in leadership, are an important component of that. We have an active and ongoing efforts around succession planning, helping to identify early colleagues in the organization where opportunities for advancement can become visible, and with professional development and opportunities moving forward. And then I think an important part of this is reflected in the last question that Phyllis answered, which is actually looking purposefully at data at the executive leadership workforce and asking ourselves the question: are we achieving the diversity and the aspirations for diversity in our executive leadership that we're talking about? And I think those are part of the accountability, the review of the work of the Anti-Racism Oversight Committee, and for us as an organization.
Yeah. Well, thank you both. Really thank you both for your extraordinary leadership through this whole initiative. And I know, I think we're all going to be looking forward to hearing the more granular reports over the next 2 town halls on the progress that's being made and the plans and the goals ahead. So I expect we'll have many more questions, but also looking forward to the information that will be shared in the next 2 town halls. So thank you both. And with that, let's see, let me just, we can go to the next slide and remind everybody that our next town hall is on February 19th at 2 p.m. And with that, I will turn it back to Marshall to close us out. Thank you.
Thank you all. Thank those of you who presented today, and thank all of you who were participated. And thank you for your support of both our vaccine program and our fight against discrimination. As Keith said, I do hope you'll be able to join us at our next town hall on February 19th.